To our surprise, it was not our idea, it was the patient's idea. Some women phoned us and said, this is an excellent medication. This was clomipramine and the forerunner of exercise. This is an excellent medication, but why should I take it the entire month when I only have problems for 1 week before menses?
Welcome to the Brains on Brains podcast, brought to you by ECNP, where early career scientists speak with the most interesting experts in applied and translational neuroscience.
So good morning and welcome everyone to the ECNP podcast series, where we try to dive deep into groundbreaking research and innovations that shape our understanding of the brain and the neuropsychopharmacology research and clinical applications. My name is Chiara Montemitro, a member of the ECNP Early Academy Board. I'm a psychiatrist and a PhD in neuroscience neuroimaging, working at Linköping University as a clinical scientist. I'm here today with Professor Elias Eriksson, distinguished professor in the field of psychopharmacology at Göteborg University, and the recipient of this year 2024 ECNP Neuropharmacology Award. Professor Eriksson, thank you very much for joining us today.
Thank you very much for having me. I'm looking forward for our exchange. This would be nice.
So Professor Eriksson received the ECNP Neuropharmacology Award for clinical research this year. And I'm reading the motivation of the committee. The award has been given to Professor Eriksson in recognition of his achievements in advancing the science of serotonin reuptake inhibitors for the treatment of several conditions, including panic disorder, depression, and premenstrual dysphoria. Professor Eriksson, you are the author of more than 200 publications and with an H index of more than 60. The recipients of many awards and several grants from both the Swedish Research Council and the European Union for both clinical and preclinical trials, exploring psychotropic drug and especially SSRI. And I think everyone would love to hear a bit about your journey. So how did you first get into the field of neuropsychopharmacology, and what has sparked your interest in studying the brain and mental health?
I could say that it was, to a great extent, accidents or chance, one could say. I studied medicine in Gothenburg directly after school, and I planned to be a psychiatrist. My father was a psychiatrist, so we lived almost at the psychiatric hospital, the own kind of psychiatric hospital. So I became interested in especially the biological aspects of psychiatry. So I planned to be a psychiatrist, but in these days, psychiatry in Sweden was in a quite problematic state. The analysis came very late to Sweden. Freud, it was not a stronghold for Freud in the 40s or 50s or 60s, but in the 70s it came, and then it markedly changed psychiatry. So it became much not very scientific and not very evidence-based. And they started to treat schizophrenia with unproven psychotherapeutic methods, blaming the parents, etc., etc. And that was all approved by authorities. So I thought, well, maybe that is nothing for me. And then it so happened that when you study medicine in Gothenburg, you have a course in pharmacology. And at that department, there was Professor Arvid Carlsson, who was the pioneer of psychopharmacology. So I thought if I do a PhD here, I could deal with psychiatry without being a psychiatrist. So I start here. So I started there, and it was so nice, so I never left. But I have, to some extent, had connection with the clinics because I've done all these clinical trials. So my research has to a great extent been clinical, but I had my basis on this pharmacology department with Arvid.
Okay. And how was it to work with Arvid Carlsson?
It was an amazing place. First of all, Arvid, of course, but you also have a number of intelligent pupils, older than I am, but younger than he was and I were. And for example, my immediate supervisor was called Kjell Modig, a very talented psychiatrist, pharmacologist and psychiatrist who played a great role in my interest for the SSRIs. But Arvid was, of course, we were very excited by working in his department because everywhere we went to congresses, people were very much impressed by our presence just because we knew Arvid. It was we didn't need to do any remarkable things. Just being from Arvid's department was a big thing. And he was a very creative man and he was smart, of course, but he was also very friendly. So he was the guy that even if you were a very young researcher, PhD student, not working directly with him, he ask you questions that make you feel very flattered, and he enjoyed discussing science also with the youngest of co-workers. So he was a very kind man and very inspiring man.
Well, I would like to know what you brought with you along your journey that came from that very first experience.
First of all, I think that Arvid has inspired the entire field of psychopharmacology, regardless if you have heard of him or not. He did so many important things in the early years. He was the first to discover that dopamine was a transmitter in brain, the first transmitter ever to be linked to a certain function. He showed its importance for motor function, leading to levodopa treatment for Parkinsonism. Then he was the first to show that antipsychotic drugs are dopamine blockers, which they still are, almost all of them. And he was one of the first suggesting that partial D2 agonism could be good for psychosis instead of neutral antagonism. He was also the first, I think, to coin the term autoreceptor and that concept. And he also developed the first SSRI. So he did really a lot of things, and especially his thinking around the synapse was very early. I think that in the early years, I think that if you had been at his department a number of years, you really understood the synaptic machinery, the postsynaptic receptors, the autoreceptors, the reuptake, and so on. And other people didn't do that to the same extent, so that you had that in the blood, so to say. Then from his personality, I think what one should learn is that the independent thinking. He never jumped on hypes. He always said what he thought. He went against the authorities as a young researcher, always believed strongly in his own data. And I think that is something we all should strive for.
Thank you. Well, one of your current projects is focused on the dopamine stabilizer, right?
Yeah.
And that was actually designed first by Arvid Carson, right? And he suggested that dopamine stabilizers could be helpful to treat several conditions that can be characterized by what he called mental fatigue. So your project is currently funded by the Swedish Research Council, and you are now testing this molecule as an add-on for the treatment-resistant major depressive disorder, right? Can you tell us a bit more about this project and how does it feel to follow in the footsteps of your teacher and mentor?
Sure. It was also accidental. Arvid, I was not at all involved in the development of these compounds. He did a lot of work with different pharmaceutical companies after his retirement. He did the work, but they sponsored it. And his idea for many years was to impact the dopamine synapse in a more subtle way, more modest way than the harsh D2 antagonists, for example, in schizophrenia and other conditions. And he became early interested in if one preferentially could affect the autoreceptors. And he, for many years, tried to develop selective autoreceptor agonists and antagonists. And he was, as I said before, one of the earliest to argue for partial agonists, such as Abilify. I think those producing Abilify have said that they were inspired by Arvid for that. However, they found a molecule called OSU 6162 that was very different from all other dopamine-acting drugs, because if you stimulate dopamine with amphetamine or other dopaminergic drugs, animals become more active. And if you give an antipsychotic or a dopamine synthesis inhibitor or something similar, they become less active. And this was a molecule that in lazy animals that had already explored their cage, their arena, they were just chilling in the corner of the cage. If you give that drug to them, they became more active, just if you had given amphetamine. But if you gave it to active animals just put in a novel arena exploring that or having been given amphetamine before, then it reduced their activity. So depending on the state of the animal and probably on the state of the dopamine activity, they could stabilize the activity. And that is why I would call them dopamine stabilizer. He was mostly intrigued by the stimulatory effect. He thought it to be some amphetamine light, perhaps. And he was old at this time. It was at the end of his active life. And his life, he was around 85, 90 when these days, but very active. And he had some interactions with neurologists, and so they started to test it for fatigue with mixed results, some promising, some, for example, post-stroke fatigue, some effect, but not as marked as they hoped for. But that is a very difficult to treat condition. So then when he was old, he asked that I should replace him in a non-profit foundation called Arvid Carlsson Foundation. And then I, so to say, inherited this compound, and then shortly afterwards he died. And my idea was that this should be tested in psychiatry, and there are of course plenty of possibilities where we would like to test the dopamine stabilizer. But I was particularly struck by as you know, one of the most evidence-based treatments of SSRI-resistant depression these days is the add-on of an atypical antipsychotic, or a piprazole, or one of the others. And I thought that this molecule is sufficiently similar to these drugs and also sufficiently different from these drugs to be a very interesting candidate here, because first of all, it does not cause any motor side effects, none whatsoever. It has no metabolic side effects as compared to other antipsychotics. So in that regard, it almost has no side effects at all.
So it has a better profile even compared to aripiprazole or recipient.
Much better. Almost no side effects at all. It can cause hyperprolactinemia, but otherwise very few side effects. So that is one thing. I think also, the atypical antipsychotics, they do have a lot of side effects. So to use them in depression, it might be good sometimes, but you would rather have something else. And then I thought it's sufficiently different. And then it is, on the other hand, just as they are, it displays affinity to D2 receptors, and it's a blocker on D2 receptor, and it has affinity to the 5HT2A receptor as a partial agonist. So it's quite similar, but also quite different. And unlike the atypicals, it stimulates locomotion in animals, which might be an activating property also in depression. So we have started a quite large study now in Sweden, placebo-controlled, and I should never say anything about the outcome before breaking the code, but it is quite encouraging. A lot of patients respond. We don't know if it's on placebo or on this drug.
Good luck.
Thank you. I could also add that the complexity of the drug, it seems, is even larger than Arvid understood. I have a very talented PhD student, Daniela Atanasovsky, and she is here with a poster regarding this compound, and she's doing a lot of interesting work, and it seems even more complicated. Our current theory is that it is at some receptor D2 antagonist, at other receptors it might be a positive allosteric dopamine modulator. So it's a complete picture, yeah.
Wow. So we are very curious to read about these findings. So I also read the protocol of this ongoing clinical trial, and I was very intrigued by the possible biomarkers of MDD that you chose to test. Because in this protocol, if I'm not wrong, you decided to collect a lot of inflammatory markers, so CRP, TNF-alpha, and also interleukin-6. Do you believe the molecule might have a specific impact on this inflammatory pathway, or do you use these biomarkers primarily because they are generally reliable indicators of major depressive disorder?
The latter, I would say. I think there is good reasons to do this in any depression trial these days. I think these biomarkers are interesting. There are also problems with them, of course. They are aberrant also in other psychiatric disorders, and it's in some trials showing the inflammatory markers to be abnormal in a certain group of patients. One factor might be that the controls are often supernormal, so they have less obesity and less smoking, and that could impact these markers. So I find them very intriguing, but also complicated to interpret. But I've always been very interested in biological markers in depression. And in the 80s, it's almost forgotten now, but then it was a lot of hype around and justified hype around the dexamethasone suppression test that was used and introduced by Bonnie Carroll and others, where you could give dexamethasone the day before and then you measure cortisol. And in severe depression, 60% had abnormal responses, while in normal controls, 0% almost. So it was quite good diagnostic confidence. And you also have other markers in depression, such as a shortened REM latency during sleep and so on. So I think the biomarkers are very intriguing. In a clinical trial like this, you cannot do something that is too complicated. So we stuck to simple measurements of these inflammatory markers. Yeah.
And keep talking about biomarkers.
Yeah.
How do you think the field of neuropsychopharmacology stands in terms of measuring brain disorder compared to other fields of medicine, for example? And we definitely face particular challenges probably, but there are some advancements in the field that make it more complex or less developed than biomarker, I don't know, for cardiovascular disorders or other disorders.
Yeah, the first part of your question is, of course, easy to answer. We are far behind all other medical disciplines in terms of objective criteria for diagnosis and objective measurements, and that has been one of the great problems for psychiatry. And I think it's not surprising at all, because the brain is so complex and so inaccessible to study. So it's not surprising that it has been used by for example, the anti-psychiatry camp to question that there are no disorders. Some people say the Church of Scientology say that there are no psychiatric disorders because there is no simple blood test that can confirm them. That is their argument. So, of course, we would like to have those for many reasons: for precision medicine, for following a treatment, for correct diagnosis, and so on and so forth. What we all hope for, and I'm not an expert in this, but of course one would hope for in the future mostly neuroimaging. I think it would be a neuroimaging that should do the trick here, that you should, by an easy MR assessment, could in some way predict what treatments a patient will have. But that will probably take some decades more before we are there.
Given your, I would say, extensive expertise in this field, if you had a superpower and you can develop any biomarker that could diagnose or monitor brain disorders with perfect precision, what would you like it to be and why?
What features, what characteristics I would like it to have? Yeah, I would like to have some molecule in blood, and this is totally unrealistic. And it should be a molecule that was state dependent, so it was a sign of ongoing illness, but it should also be somewhat abnormal even before the onset of illness, so you can predict the illness, and then it could serve you in the choice of treatment. Would this patient be respondent to drugs or not? And if yes, what drug? And then it would be very nice and the dexamethasone suppression test, in fact, in some way fulfilled this criterion, that there were studies showing that if you had patients that seemed to have improved and be in remission, if they still had a pathological DEXA, it was much larger risks that they should relapse shortly thereafter. But if their DEXA had normalized, then it was much less of a risk. So this, with my superpower, the blood test developed, this would also be a signal whether the patient had really improved or whether she or he would need further treatment.
So we can say a time varying
absolutely
that we can monitor continuously to follow patients.
Yeah, for those of the listeners not knowing the difference, when you talk about related biological markers, that is something you have all your life, but you have then a greater risk for a disorder. State-dependent markers, those that become abnormal when you are ill and become normal when you are healthy. And those are the most interesting, I think. Or both are interesting, but that would be, from a clinical point of view, helpful.
You've conducted a lot of research on antidepressants, as we heard here in Milan. And as a clinician, I often feel that actually your papers answer a lot of clinical questions that we are all obsessed with. One example is your work on premenstrual dysphoria, which led to the introduction of intermittent SSRI treatment. Today, this treatment is actually the gold standard, the first-line therapy that we have for PMDD, even though it initially it challenged the well-established theory of late onset of SSRI efficacy, right? How difficult it was to challenge this long-held theory, and were the results as surprising to you as they were to the rest of the field?
Yeah, I think that what was interesting, what we found intriguing with premenstrual dysphoric disorder is, first one could say, I was somewhat surprised that it has been very neglected in psychiatry. It may be that it just afflicts women. It may be that it is a condition where a mild form is quite common. And it is a common phenomenon that when there is a condition that is in its mild form quite common, people neglect the severe form. That's the same for social phobias, the same for ADHD. Some people question that those with severe form really should have a diagnosis. And that's the same for PMDD. So I was mostly, when I entered this field, I was mostly surprised that so few other people in psychiatry had studied it. And the reason we started was, in fact, that we had done animal experiments on interaction between 6-year-olds and serotonin, and studied compared male and female rats with respect to certain turnover and so on, with Arvid, for example. And then I was approached by gynecologists who said, well, you are interested in that, and I'm interested in PMS, as it was called then, but we have no treatment. Couldn't one test possible treatments? Don't you have any suggestion? And then, in fact, we first did quite stupidly another trial with some other drugs, and that was a failure. But then we realized that the optimal drug here should be a serotonin reuptake inhibitor for the reason I mentioned in my lecture yesterday, that it is well known from animal experiments that the major physiological role of serotonin is to dampen sex-driven behavior. The most common side effects are reduced libido, which obviously is sex drive is sex-driven. Aggression in animals is sex-driven, in males, testosterone-driven, and so on. And serotonin dampens all that. And what is well known is that PMDD is driven by the fluctuations of the female sex drives, especially progesterone, probably. So we thought it would be obvious. So it was not that the drug we used was an antidepressant. That was not the reason, because I have never regarded PMDD as a form of depression. And I think it's quite unfortunate that it in DSM is under the heading of depressive conditions. It's something else. And it's clearly, we have asked a large number of women in a big survey what is the most cumbersome symptoms, and they always say irritability. That is number one. So that was very good reasons for testing it. And then, to our surprise, it was not our idea, it was the patient's idea. Some women phoned us and said, this is an excellent medication. This was clomipramine, and the forerunner of SSRIs. This is an excellent medication, but why should I take it the entire month when I only have problems for 1 week before menses? And we said, well, this has a long, sluggish onset of action, so you have to do it. And then they phoned back, some of these women, and said, well, I didn't care about what you said. I tested it and it worked fine. I started at ovulation and it works fine. And we heard it from several patients, which reminds you that you should always listen to patients. So then we did the first clinical trial where we used this intermittent treatment and realized that here we had a totally different picture, a very short onset of action. Immediately you have, in fact, an effect the first day you take it, if you take sufficiently high dose. So that, for us, opened up new thinking about how do these drugs work in different conditions, and it strengthened our view that PMDD should not be regarded as a variant of depression. It is not, it is something else.
Mm-hmm. So that SSRI actually can have both state-dependent and trait-dependent effects.
Yeah.
Their effects in a way change based on the brain state.
One could say that. And a problem for us is that when, not for us, but for clinicians, when they suggest that women should take this medication, we said, well, I've heard that it's an antidepressant. I'm not depressed. It has some kind of negative stigma that taking a psychoactive drug. But in PMS, it does something totally different, and it's intermittent, and you don't need it. 3 out of 4 weeks, you don't need it. But it can rapidly manage your symptoms when you take it.
Why do you think the gender effects, the gender balance, for example, in clinical trials, or the gender effect on treatment with different drugs was actually neglected for so long time?
I don't really agree with that in psychiatry. In other fields of medicine, you definitely have had the problem that women were excluded from clinical trials because of the risk for pregnancy. I don't think I've seen that so much in psychiatry, because women already in the early antidepressant trials, there were in fact both sexes, both genders. But what is important is that people didn't understand that they should analyze the data separately. Mm-hmm. And that is, I think, a more important point. I think if you can go back to early studies, and you will have a wealth of information where both men and women have received these drugs, but people have not realized that it is worthwhile to analyze the data separately. And now we are, in fact, preparing a paper, whenever that will turn out, that where we, in all the data we have from SSRI trials and SNRI trials and mirtazapine trials and tricyclic trials, we have patient-level data in our database to really explore if there are differences between men and women in responding and in other aspects.
You addressed a lot of claims about antidepressants, efficacy and inefficacy, actually. And you revised data from various clinical trials. Now you just told us about this gender analysis, but actually you did a lot of other analysis to separate, let's say, patient-driven data, so patient-based analysis of this data. And you discovered that actually many trials showing non-superiority for SSRIs were based on overly severe measures of depression or the use of wrong markers for improvement and remission. This highlights a broader issue with clinical trials, probably, right? What is your suggestion for early career scientists? What should we focus on? What is the take-home message we should bring with us to improve clinical trials in psychiatry?
Yeah, that's a good question. I would like to, if I may, have some different comments on this. First of all, I would like to say that you are quite right. We have shown in a number of studies that SSRIs are better than claimed. And the reason that they are often claimed ineffective is there are several reasons. One of the most important is that one has measured outcome with a scale that also includes the side effects, and that makes a strange picture. Also that one has included suboptimal dosing and several other aspects. I also would like to emphasize that I'm fully aware of the fact that SSRIs are by no optimal drugs. You have a lot of non-responders, absolutely. I think they are somewhat less effective than the early tricyclics, such as amitriptyline and clomipramine. So they are definitely not perfect drugs. But what we have reacted against is that there is, in fact, a campaign against these drugs, where even in scientific papers, there are often, in decent journals, papers that on a very unscientific basis question these drugs. And so we have found it in a way important. Large part of the psychopharmacological and psychiatry research actually just ignore the critics. But I think that we must address this in a proper manner. So this is what we have tried to do. And we have also studied other aspects that are not as controversial, but also may benefit from studying it on a patient level and on a item-based level. When it comes to your question then, well, the largest problem here when it comes to clinical trial in psychiatry and in other fields as well is that they have, because of maybe overly regulatory restrictions, have become so extremely expensive to conduct. So it's very difficult these days for academia to conduct company-independent clinical trials. So we are very much in the hands of the drug companies with respect to which issues will be addressed in clinical trials. The trial I described that we are doing now, that is totally independent from Big Pharma, but that is because we happen to get a huge grant from the Swedish Research Council, but that is quite uncommon that you do. And so when I was young and we did all these PMDD trials, most of them were totally independent of the drug companies, but we could afford to do them because it wasn't this enormous amount of costly thing. Just to pack the tablets, just to pack them and to have a label on the package cost 2 million Swedish crowns or 3 million Swedish crowns, which is 10 Swedish crowns on €1. So very expensive. So that is one problem, that we have so few clinical trials independent from the drug companies. Drug companies do some good work and some important trials, of course, but they are not at all interested in own drugs, and they are only interested in certain indications and so on. So that's one problem. When one should, if you have the money and if you can design a trial, my main message here would be that one should look really for, not rely too much on the sum score of a rating scale. One should look for a key thing that you would like to impact. In PMDD, for example, when we focused on irritability, that's when we saw the really huge effect. If we made a sum of all the different symptoms, breast tenderness and bloating and etc., then we had not as strong effect. So I think and exactly the same in depression. When we focus on the key symptoms, depression, psychoanxiety, depressed mood, psychoanxiety and so on, we see clear-cut separation. When you include also back pain and stuff like that, it's less obvious. So that would be my general advice, both to the drug companies and to academia, that when doing clinical trials, think a lot about the effect parameter and don't be too conservative. Especially the companies have been very conservative, because in the very early trials, people use the Hamilton Depression Rating Scale. They have continued to use the Hamilton Depression Rating Scale. They know that FDA and EMA would accept that outcome parameter, and they haven't. Now they are starting to use Montgomery also, but there's very little room for creativity here in the clinical trials done by the pharmaceutical companies. They probably believe they cannot risk to use a new scale, which is unfortunate.
On this point, do you think psychedelics will help the field against these anti-psychiatric theories, and especially about the non-serotonin theory of depression? Do you think psychedelics will help us improving our understanding of SSRI? activities and brain mechanism of depression?
Yeah, I think so. Of course, it's a good question. And on the one hand, people say now everyone understands that serotonin is not involved at all. Serotonin was not important. You have the Moncrieff umbrella analysis 2 years ago. And on the other hand, you have psilocybin hype, and that also acts via serotonin. So serotonin has made a comeback kid. After being counted as down and out, serotonin makes a comeback. We have done some animal experiments with psilocybin together with a guy from Iran visiting us, a young student, Ashkan Vaisi, and also Daniela Tanasovsky. So quite interesting results in mice and rat. We haven't done anything in humans in psilocybin field, but some of my close co-workers are involved in that kind of study. I am, as many others, interested, but not entirely convinced. And I realize, as many other people have realized, that the blinding issue here is a problem, that for all other drugs, we always think that the placebo-controlled trials, where you have at least a decent blinding, is a prerequisite for acknowledging an effect, and here you cannot blind. Or I have an idea. I have often asked people, why don't they compare it with ketamine? Because ketamine may also cause some hallucinations, so that could be a decent blinding. And then, of course, both have an antidepressant effect, but what is claimed is that psilocybin, that effect should last for at least several months, while no one claims that the ketamine effect would last for more than a couple of weeks. So then one could have an endpoint assessment after many weeks. So that might be a solution. I don't know. But I don't know if anyone is doing that. But no, so far, I'm encouraged by this interest in psilocybin, but I don't know yet what will happen clinically with this.
When you faced all these claims about antidepressants, inefficacy, and SSRI not being the right drug for depression, etc., do you think that actually all these debates, I mean, you face these theories in a very proactive way, actually. You analyze data sets, and you asked for more data actually from the drug companies. So do you think that actually all these debates pushed you to be better, to improve actually your understanding?
Yeah, it's an interesting, in fact, I think we would not have started this project if I had not read a book by Irving Kersh, the psychologist professor, many years ago. And I did not agree with much of what he said, but that was the incentive for us to start all this. And I think this have been very interesting avenue of research. So you are quite right. That was helpful. Thank you, Irving, for that. And on the other hand, I am really, let me say this again, within a reasonable scientific questioning of a drug is often very important. And we have that debate, and I've had that debate about all classes of psychiatric drugs, and we should have that. So I'm not at all a proponent of all psychiatric drugs and all antidepressants. But the problem here is that we have this pseudoscientific campaign against them. And you have had various anti-psychiatric campaigns throughout the decades. In the 70s, when I was young and hesitated to enter psychiatry, then it was mostly about schizophrenia. People said that is not a real disorder, that it's just a consequence of the capitalistic society and stuff, or it is caused by the mother being mean when you are a kid and so on. And then, or being cold and not sufficient effective. Then 15 years or so, it was very popular to question the treatment of and diagnosis and treatment of ADHD. We had a big fight in Sweden about that, for example. And these days, it's mostly antidepressants. So there have been this kind of psychiatric waves throughout the decades. I think that is very problematic because I hear a lot of patients having read this kind of stuff and not taking medication when they obviously need it. So I don't like it.
Talking about the complexity of the human brain and of neuropsychopharmacology, of course, I recently watched a wonderful video from 2015 Molecular Frontiers Symposium, where actually you were the interviewer of Arvid Carson. And the video is still available on YouTube for those who are interested. And one of your sentences actually really struck me. And it was, neuropharmacology is actually a young science. We only have fragments of knowledge about the brain. Our work is to put them together to improve people's lives. And in the last decade, I think neuropsychopharmacology has grown, and significantly probably, and also thanks to your contributions. Using your metaphor, we are definitely, let's say, assembling a very complex puzzle. As a young researcher, I'm always, sometimes at least, feel overwhelmed by the amount of knowledge that we have right now, right? The impressive number of fragments of these pieces of the puzzle that we have to put together. How do you see the field managing these rapidly expanding areas of knowledge? And how do you think we are approaching a point where we'll need to reorganize our understanding in order to move forward?
It's a very good question. I've not ever received that question before. I think it's very good and difficult to answer, but I totally agree with you. I also feel overwhelmed. If you go to a Society for Neuroscience meeting and see all the posters, you get dizzy and everything seems to be studied. I think I would emphasize one thing, and I mentioned this briefly yesterday. I think now we have all these new molecular biology methods, and they are extremely encouraging, of course. And as compared to what we could do when I was young and what one could do today, is the difference is enormous. So, of course, in the long term, this is bound to create great advances in terms of treatment. But it could still be many decades ahead, because the more you learn, the more complex the brain appears. And I think it's fair to say that in spite of all the billions invested and all the marvelous methods, both when it comes to imaging and other clinical stuff, and when it comes to preclinical work with optogenetics and whatever, this has yet not led to any new treatments. None, zero, nil. Even ketamine, the most recent, which I really think is an important game changer, was serendipity, according to Jon Christel. They hadn't expected the patient to respond. So I don't think one should be very disappointed. Why don't we have any new drugs? I think it's very easy to understand. All the present drugs, there were early serendipity findings, and then you have what I called yesterday old school pharmacology, where you started your interest from the drug and then explored the mechanism of the drug and then constructed new molecules and tested them and so on. And that has been an extremely successful avenue of research. You have much less of new serendipity findings these days because of regulations, what you can do with patients, which of course is good. But you have much less of that, but still you can build on the knowledge you have with active drugs. What I would like to see perhaps more of is that young neuroscientists, often background in molecular biology, use these novel methods not only to relate them to behavior of animals, but to use them to join forces with old school psychopharmacology, using these new methods to a greater extent to explore the mechanism of the drugs. I think, of course, there are a lot of such research, but not that much, in fact. So in the novel era of molecular biology, neuroscience, you should not forget about the old psychopharmacology path. And I think by increased interaction there, and therefore I think ECNP has a lot of nice initiatives in that area where you try to integrate the clinical, also within preclinical psychopharmacology, we are nothing without the observations of the clinicians, nothing. And the clinicians would not have any of the new drugs if it had not been for preclinical evaluation, most of them at least. So I think even more interaction there.
Yeah, actually on this point, we recently started a new activity here at ECNP that is Meet Your Translational Match.
Yeah.
We want to favor the meeting between people who work on the same field, but actually have different perspective, because as you said, clinical and preclinical don't always talk much. So we think that it's very important that everyone can find their own match on the other side.
Absolutely. Congratulations to that. It's very commendable. I worked a little in psychiatry as a very young doctor when I was young, but since then I have only done clinical research, I've not worked clinically for most of my professional life, but I had enormous help throughout the years that I have so much interacted with clinicians, so many ideas and experience. They have conveyed experience with different drugs and so on. And today I see these very sophisticated group of neuroscientists where there is no MD in the vicinity. They never hear from a psychiatrist. They often do not come to our meetings. They do basic neuroscience, but I think it would be good if they interacted more with psychiatry. Absolutely. So that's a good initiative.
Well, you put together these two pieces of science in your career because you were very successful both in preclinical and clinical work. Yeah. I mean, but at the same time, I think you are a very good example of how much the communication with other branches can improve our knowledge and our work, given what you said about PMDD, for example, the gynecologist helping you in that.
But you are yourself a basic scientist and a clinician, so that's a perfect combination. If you have time to do both, that is, of course, very good. But otherwise, you should have the kind of interaction, absolutely.
Looking back at your career, is there a piece of advice you would like to give to the young scientists, an advice? Yeah. Especially related probably because we talked a lot about science, but how strong is the impact of science in your life, probably also in your personal life? So what should a young scientist focus on? It's a difficult question because I would have somewhat different advice depending on if you really would like to promote your career or if you would have a joyful professional life. And it's not exactly the same. I'm a bit fed up with the hunting for high impact factor papers and the hunt for enormous mega grants and all that stuff. I think that to have those papers put in the best journals and to have these enormous grants, you usually often these days have to follow the hype. Do stuff that is popular these days. So if I should give an advice to a young researcher really wanting to have a rapid career, maybe one should look what is the current hype, find a big, rich group that does research in that area and get along and hope for some high impact papers, and then you have your own grants and everything is going fine. But I think it's too much emphasis on these factors. When I was young, it happened that you congratulated a colleague from a different department. Oh, I heard about your new discovery. That was very interesting. Today, people are congratulating each other. I heard about your new grant, or I heard about your award, or I heard about your Nature paper. It's not the real thing anymore, more about the symbols of success. So I don't know, that might be effective. A more joyful career is to really go for a group where you like the people, where you have nice supervisors, nice coworkers, and where you are doing something original that is maybe not in the midstream of the current hype, but something original. So the best thing is, of course, if you could find a middle way, do both. But I've always followed the latter. Of course, I was at the Department of Carlson, that my supervisor in my PhD, he had no big grants and so on, and I was his only PhD student. But he was a very bright guy, and he was the first to suggested clomipramine to be used for panic. So that is how I was involved in testing clomipramine for panic disorder, and then it became the first antidepressant ever approved for panic. So that was very fun. A small group, smart guy. We had no interest for impact factors. Arvid was not impressed by impact factors at all. He thought they were destroying science. He said that if you have strongest motivator should be science.
Arvid said that if he had really good discovery, then he put it in a very humble journal, because then no one noticed for several decades. So then he could continue to doing work without having competition, and sooner or later people would realize. That was, for example, the first paper on that neuroleptics block D2 receptors or dopamine receptors. That was in a very small Scandinavian journal, and it was not cited at all for many years, and then it became a science citation classic. So that is some advice. And then for works in psychopharmacology, I really would recommend basic neuroscientists, as we said before, to read psychiatric papers and go to psychiatric congresses and meet and learn to know psychiatrists, and not just work in a bubble of molecular neuroscience, but reaching out to clinicians.
Thank you very much, Professor Eriksson. It was a pleasure talking with you.
Thanks for listening to this podcast from ECNP. The views and opinions expressed in this podcast are those of the interviewee and do not necessarily reflect the official position of ECNP. The content of this podcast should not be used in any way as the basis for treatment decisions.